All right, so hi, good morning, everyone. So we are back here with again the 5 a.m. sessions, and we'll be now doing it till the FMG examination, right? So your mentor duo is back on Insta, and now the 5 a.m. sessions are too back. So today's session, I'm starting this session with the orthopedic PYQs that you have usually on the back of your workbook. Okay, so let's start. In a while, let me just adjust my phone so that you all can see the questions and how to just catch the keywords and how to solve the MCQ in your exams as well. All right, so just give me a moment, and I'm just sharing or just putting this phone onto the proper manner so that you all can see. All right, so let me try to fix it so that you all can see it from a proper angle here. Let me just try to see if it works for you. Okay, so all right, let's see. So people on Insta, if you can please confirm if it is fine. You all can see the letters very clearly. If you can see on Insta, Abhinandan, Pradha, Rohan, Samuel, the best ortho doctor. Okay, wonderful. Jairaj, if you can please confirm if you can see the screen properly. Is it fine with everyone? You all can make out? Yes. So fine. All right, so let's start with this. All right, everyone, let's start with this. So the very first one, we can start. You can keep on putting your messages in the chat box as well. So now let's start with the very first one. The diagnosis of a patient. These are all your PYQs, right, from the past few years. And I'll try to give you the explanations how to some questions are factual ones, some are very, very conceptual ones. So let's see how to crack all of them. Okay. So number one, the first one, the diagnosis in a patient with the external rotation of the hip. What do you say? What should be the answer for this one? The first one. External rotation. When you say external rotation, what exactly this means? What pathology is it most likely pointing towards? What do you say? Answers? Hip external rotation. In which all conditions should we be seeing this? Okay. C, dislocation of the hip. And if you say dislocation of the hip, which dislocation are we talking about? Which dislocation are we talking about? See, this is a very, very important topic, and this concept here is very, very important, right? This concept has to be anterior. Oh, yes, you are right. So this concept here is very, very important, and you all should be aware of this. In which pathology of the hip, किस pathology में the patient presents to you in what kind of attitude? All right. So C is the right answer. Dislocation of the hip will come with the external rotation. Okay, and in the external rotation, we should know that it is most often a anterior dislocation with which the patient usually comes to you, right? It is anterior dislocation. Perfect. Now let me show you a table over here which will help you out to understand where all the fractures can be, right? See, look at this note here. Okay, this note is very, very important, and you all should be aware of this. This note is telling you about that in which conditions the patient can come to you with what all kind of pathologies, right? अगर ये लिखा नहीं है तो लिख लो साथ साथ, and it will help you to solve many MCQs. In fact, it has more than 10 questions for you, this one page, right? देखो, abduction attitude of the hip. Whenever you're talking about the abduction attitude of the hip, you know abduction in the hip joint. First of all, we are talking about the hip pathologies only, right? So abduction in the hip, you know very well that this hip abduction, it usually comes to you with limb lengthening, correct? This comes to you with limb lengthening. That is another concept, that whether this lengthening, it can be a apparent lengthening or it can be true lengthening. That is second concept, right? But the very first thing is that abduction has to come with limb lengthening, right? Apparent or true is always the second concept. Now, in the question, they mention that the patient is coming to you with the limb lengthening, right? When the patient comes to you with limb lengthening, what all are the possibilities? So the first diagnosis that you should always consider is a anterior dislocation of the hip. If in your question there is a history mentioned for trauma, right? If there is a history of trauma, then it has to be an anterior dislocation, right? Many times it will be there, it will not be there, but then depends. Second condition can be synovitis, right? Now you all know that this synovitis is basically a inflammation or infection of the synovium, right? This can be a inflammation or infection of the synovium. Now, whenever we usually talk about synovitis of the hip, usually they are pointing towards infected one, right? So what all are the possibilities, and how do we differentiate that what can be the possible reason for abduction, lengthening? See, if your patient is a case of 2 to 5 years of age, right? Involvement of the hip and knee, they're more commonly seen in patients of septic arthritis. They're usually the kids 2 to 5 years of age. And when this septic arthritis occurs in a child less than 1 year of age, what do we call it? Less than 1 year of age, what do we call it? Answer batate raho saath saath. Otherwise it will be a teaching again. It has to be a revision. So it will be called as what? Tom Smith arthritis. Remember this? Tom Smith arthritis. So septic arthritis का patient कौन होगा हमारा? Septic arthritis patient has to be a child 2 to 5 years of age, right? Tom Smith arthritis is the septic arthritis of hip in a child less than 1 year. That is an infant, right? That has to be an infant, okay? And you all should remember this. You all should remember this, that whenever we are talking about, whenever we are talking about the septic arthritis, most commonest foci, whenever we talk about the septic arthritis, most commonest foci, where is the most commonest focus? It is on the head of the femur, right? So in septic arthritis, you should know, when you look at the hip joint, this is, let's suppose, the hip joint here, right? This is the hip joint, the lesser trochanter, the triradiate cartilage like this. So focus can be here on the acetabulum or in the head of femur. But in Tom Smith arthritis, it has to be at the head of the femur, right? Then transient synovitis is not something which is usually asked. It is not usually asked. It is the infection of the synovium, inflammation of the synovium, which is usually occurring after upper respiratory tract infection, after URTI, right? This condition is more common in a child of the age 5 to 12, okay? And this is also called as observation hip because it is the synovitis for a transient phase, right? It is a subtle kind of infection which usually doesn't destroy the hip joint, okay? So another very, very important patient who comes to you with abduction and external rotation, okay? Abduction and external rotation. Who is that patient? The stage 1 of tuberculosis of the hip, you remember? The stage 1 of the tuberculosis of the hip. And here I want you to remember something very, very important, that in septic arthritis, first the focus reaches where? The infective foci reaches where? The head of the femur, right? That is septic arthritis. But when you say about the tuberculosis, where does the foci reaches? It reaches to the acetabulum. Okay, so number 1, head of the femur, tuberculosis, acetabulum. That is a big difference. So in your exam, if they ask you one-liner, what is the most commonest foci of TB hip tuberculosis? It is acetabulum. If they simply ask you about septic arthritis, it has to be the head of the femur, right? I hope this point is fine with everyone, right? This should be fine with everyone, okay? Now, this is about your abduction and external rotation. Okay, so don't forget, if your question says there is abduction, there is lengthening, there is external rotation, our answer has to come from these 2 to 3 pathologies. Okay, now the second one, if in your exam they mention that the patient is coming to you with adduction and internal rotation. Now adduction and internal rotation, adduction, you know, will be having what kind of presentation in the limb? It has to be shortening, right? Adduction comes up with shortening of the limb. Okay, now internally rotated shortened hip can be seen in which all conditions? Again, if it is a case of trauma, let's suppose this is a case of trauma, right? They say the patient is coming to you with the attitude of the hip in adduction and internal rotation. And please don't miss out this thing. This in fact can be a image based question also. Sometimes they may give you the image based question also on this, right? The posterior dislocation of the hip. So what exactly we see in this? Let me show you something here. So just have a look on this. I'll show you how the image-based question can be asked to you. So in image-based question, you can be given one of these pictures, right? Instead of mentioning the theory only, they may sometime give you some image, something like this. Look at this one, right? And they simply ask you, a 30-year-old met an accident and presented with the following finding, right? What is the most likely diagnosis? Now looking at this attitude, what do you say? At hit this one, what do you say? What is the pathology the patient might be suffering from? If there is history of trauma, they have already mentioned, it is traumatic. So how is the hip? Any answers for this? What this should be? A, this has to be the anterior dislocation. Why? The hip is already into abduction and external rotation, right? So it can be an image-based question. It can be a theoretical question. It may go either ways, right? So don't just get confused here. Okay, so adduction now. We are talking about adduction, second part of this. So if they say, if the patient is coming to you with a shortening, if the patient is coming to you with adduction and internal rotation, what all can be the possibilities? The possibilities can be, if it is trauma, posterior dislocation, right? This posterior dislocation is the most commonest type of hip dislocation. You know that very, very well. And what is the usual mechanism to have this posterior dislocation? How does somebody have it? So, you know, this posterior dislocation usually occurs by the mechanism we learn as the dashboard injury, right? That occurs as dashboard injury, right? How? When the patient is sitting on the front seat of the car with adduction and internally rotated hip, that means both the hips close to each other. So there is an impact from the front and that causes a dislocation, right? So there has to be a traumatic thing. Don't miss out. I would suggest that none of you should miss out actually, you know, the dislocation of the hip. This is one of the most important topic you have. It can be a image-based question. It can be a theoretical question, one-liner, clinical scenario-based. So dislocation of the hip should be learned, right? So X-rays, clinical part, the X-rays part, or theoretical way. You should be able to crack them all the three ways. Dislocation of hip is very, very important, right? Then we have another condition in the neonate. When your patient is a neonate, the condition can be CDH or DDH, right? The condition can be CDH or DDH, congenital dislocation of the hip or developmental dysplasia of the hip. Now, when you're talking about CDH or the DDH, you should know, when you talk about the CDH or DDH, you should know that what all clinical test they can ask you in your exam, right? The clinical test for CDH. So you should know the first test we always learn is Barlow's test, right? Hip brought into adduction and you push, right? So Barlow's, it assesses the hip for dislocation. You remember? Second test after Barlow's is positive. What we can do is Ortoloni. Ortoloni, how does it help? It helps in the reduction. You abduct the hip and you pull. And third is the comparison of the position of the knee. You remember the child being light supine and you compare the position of the knee. What do you call that? That is called as the Ellis test or the Galeazzi sign, right? Ellis test or the Galeazzi sign. You compare the position of knee. These three you must not forget. These are very, very important three names, right? Investigation of choice, you should know it is always MRI. And if they ask you for screening, the screening, what is the investigation of choice for screening? Anyone? Bata do usko jaldi se. If MRI has to be the investigation of choice, then what should be the investigation of choice for screening? Ultrasound. Very good. So it has to be ultrasound. Wonderful. Right? So CDH, you should not forget. These are one-liners also, image-based also, right? You should be very much aware of them. Very good. Now coming on to the next one. Now, if another very, very important topic, see, posterior dislocation is important. CDH itself is important. And the patient number 3, who can come to us with shortening, adduction, internal rotation are the stages of TB. And this is again one of the most important, you know, MCQ for your exams, the stages of tuberculosis. Okay, so first stage we have seen, just to remind you, just to recall, the first stage here you have seen, the first stage, it comes with what? It comes with abduction and external rotation, the first stage. But stage number 2, stage number 3, stage number 4, how do they come? With adduction and internal rotation. All right. So how do we get the MCQs? How are we supposed to learn this? See, stage number 2 of TB hip, what do we call that? The stage number 2? What do we call this stage number 2? It is early arthritis, you remember? And the MCQ they are going to ask you from here, what is the first radiological change, right? What is the first radiological change that we see in tuberculosis of the hip? What is the first radiological change that we get in the tuberculosis of the hip? So what do you say? The first radiological change is periarticular osteopenia, the blackening around the joint surfaces. Your question number 1. Right, the periarticular osteopenia. Keep answering. Don't miss out. Okay, don't just listen. Keep answering. Some will be right, some will be wrong, and if they're wrong here, it will not be wrong in the exam as well. Right, so you can easily mark them correct in your exam. Now, stage number 3. What is at stage number 3? It is a stage of late arthritis. Now here, what do we get? We get the destruction of the bone. decrease or loss of the joint space, decrease or loss of the joint space, and the fourth one is advanced arthritis, where we get what kind of feature? Gross shortening, and that comes with radiologically what do we call as the wandering acetabulum, right? Radiologically what we learn as the wandering acetabulum. Okay, so I want everyone to remember early arthritis, your question number 1, the first radiological sign, that is periarticular osteopenia. In which stage of TB do you see the real loss of the joint space or the true shortening? Because of loss of the joint space, there will be true shortening. So that is stage number 3, late arthritis. Where do we see wandering acetabulum? This is stage number 4, that is advanced arthritis, right? So these all are your MCQs, question 1, question 2, and question number 3. Okay, so another patient who is coming to you with shortening and adduction, right? Shortening and adduction. All right, so these two are the most important ones. Number 1, abduction, external rotation or lengthening, and adduction and internal rotation or with shortening. So whatever is mentioned, according to that, you have to answer in your exam as well. All right, you'll have to answer in the exam. Now, little unusual to ask you this question, right? But still, you should have in your mind, abduction in the shoulder is usually accompanied by external rotation, right? Adduction is usually accompanied by internal rotation. But then if you see the third one, here we have a mismatch, adduction and external rotation. The adduction and the external rotation. Where do we get this? Now I want you to remember two important ones. I want you to remember two important pathologies here. Number 1 is Perthes, right? Number 2 is SCFE, right? Number 1 is Perthes and number 2 is SCFE, okay? So how are we going to make a differentiation in our exam that who is my patient? See, first of all, you should remember that Perthes is osteochondritis, right? You remember? Perthes is what? Osteochondritis. So you can see the destruction of the head of the femur. Now, don't get confused with this patient of septic arthritis. Septic arthritis patient is usually again a child of the similar age group, right? Again, hip and knee are involved. So hip involvement, don't confuse septic arthritis because Perthes is not infective one. It is just an inflammatory one, right? So your patient is 4 to 8 years, usually a male, and usually comes to you with recent trauma, which might have occurred 2 weeks back, 3 weeks back, a month back, 2 months back. This is recent trauma. Most important clue will be that these Perthes patients, they usually come to you with adduction and external rotation, right? They usually come to you with adduction and external rotation, and synovitis patients are coming to you with abduction and external rotation, right? So there should be no confusion in this, okay? So Perthes child, recent trauma, male, 4 to 8, and with this kind of attitude when the head of femur has gone into necrosis, right? So always look for some history of trauma. All right, SCFE. Now who will be your patient? Again a mismatch, adduction and external rotation. Adduction and external rotation. So again your patient is going to be a adolescent age group patient, right? And they usually come to you with acute trauma. The child just slept down. Or he just had a history of fall and this attitude happened. Okay, so I want everyone to remember all the three: abduction, external rotation, adduction, internal rotation, and adduction plus external rotation. Is that fine? Is that fine with everyone? If there is any doubt here, just put it right now. This is your part 1, which I want everyone to remember, right? The regional conditions, whether post-trauma or whether post-inflammation or infective one. Is this fine with everyone? Is this okay? Just waiting for your rewards. Have you all opened your workbook? अपनी workbook को open रखा है सबने? So now you all can just, shuffle up the pages and you all can see what all we have discussed. Can you please share this page in group? No, I can't share. First you have to write down yourself. बेटा सिर्फ इकट्ठे करते रहने से कुछ भी नहीं होगा. अभी पहले लिखो इसको. Page share करना is never a problem. But until you write down, you will never be able to understand it. फिर रटते ही रहोगे बस. लिखो साथ साथ. I'm giving you enough time. I don't mind sharing, but at least write down whatever you can. अपनी workbook में लिखते जाओ. You have blank pages in your workbook, so keep on writing. Right? So part 1 is fine with everyone. विशाल लिखना भी शुरू करो. I'll share it later, but लिखना भी शुरू करो उसके साथ साथ. Okay, is this everyone? Okay. All right, this is fine. चलो, अब आते हैं next पे. About next वाला part. Next वाला part is again very important. Now, by chance in your exam, you get an MCQ where they give you another scenario. This is part 2. Okay, this point number 4 is part 2. This is again a different topic, different condition, but a very, very important one again, right? If they give you an exam that patient is having shortening and patient is having external rotation, right? Patient is having shortening and patient is having external rotation. They are not mentioning on abduction, adduction directly, right? And these always comes to you with the history of trauma. These always comes to you with the history of trauma, right? If the external rotation and shortening is less, if the external rotation and the shortening is less, what is the usual diagnosis? It is intracapsular fracture, right? It is an intracapsular fracture. So that usually goes in favor of fracture neck of the femur, right? So if the rotation is less and if the shortening is less, then usually it is intracapsular fracture, which goes in favor of neck of femur. But if by chance they give you a picture where they just tell you that the patient's foot, it is falling completely onto the couch, right? The lateral margin of the foot is falling out directly onto the couch, right? Then what exactly is the diagnosis? Then diagnosis is going in favor of any extracapsular injury, right? Then it goes in favor of extracapsular injury. So when rotation is more, when shortening is more, it is extracapsular, which can be a fracture intertrochanteric, right? Or which can be a fracture neck of femur, which is basicervical. But this you have to exclude, consider this one. IT fractures or the fracture neck of the femur like this, right? So please remember how the patient presents to you in which attitude, right? So see how many topics we have covered. The fracture neck of the femur, the trauma to the proximal femur we have covered over here, right? That is point number 1, right? This topic definitely separately also is very, very important, right? Number 2, SCFE. Number 3, Perthes disease. Number 4, tuberculosis of the hip. Number 5, CDH. Number 6, trauma, dislocation, right? Number 7, transient synovitis. Number 8, septic arthritis. This one page will help you to understand so much, and looking at the language of your question, you should be able to make out. Right? विशाल लिख रहे हो कि वेट कर रहे हो मेरे शेयर करने का ग्रुप में? Okay, so please write it down. लिखोगे, थोड़ा लिखोगे तभी याद होगा. लिखते जाओ उसको साथ साथ. Okay, that is your first question we have discussed. That is the first question. Very good. That is the first question we have discussed, right? I hope it makes sense now. Every question doesn't have that one topic, right? Every question has these 4 options. Okay, so you should be aware about each one of them. That is your first, question over here, right? Sometime the questions will be conceptual one. Now this is what you call a conceptual question. Okay, now first one, the question number 1. The question number 2 is now a little factual one. What you see, you have to answer. Identify the fracture shown in the image. So what is the fracture we can see in the image? You can see this now. This now is the part of olecranon fossa and the olecranon here. This one you all can make out, right? This is ulna. This is ulna, and we can appreciate there is a fragment in front of ulna, and there is a part of the radial head which is gone, right? But we don't see here is any kind of dislocation of the elbow. The posterior dislocation is not visible to us. Okay, so what we can see, there is a fracture of the radial head. Okay, there might be a fracture of the coronoid. Okay, this might be there, but posterior dislocation is not there. अब मुझे ये बताओ, please tell me about this. If a patient comes to you with all the 3, radial head, the coronoid, and the posterior dislocation number 3. If a patient comes to you with these 3 injuries, how do we label that patient? If a patient comes to you with all the 3, how do we label that patient? That patient is labeled as, how do you call it? Can somebody say? What do you call that? Come on. Little quick. So how do we see these patients? This is called as 3 things injured at a time. So that will be called as what? The terrible triad of elbow. Right? The terrible triad of elbow. Okay. So that will be terrible triad of elbow. Posterior dislocation, coronoid, and the radial head. But in this picture, I can only go with the radial head part. Right? In this picture, I can only go with the radial head part, right? So that is radial head fracture. That is radial head fracture. Right. So, all right. So Ashwari sir is also there. Hi boss, good morning. I can see, yeah, you are absolutely right. You are already a genius. How can you be wrong? Absolutely correct. Okay, so this is the radial head fracture. Fantastic. So terrible triad of elbow. Okay, posterior dislocation, radial head, and the coronoid. That is terrible triad of elbow or the O'Donnell's terrible triad. Perfect. Now another clinical one. Another one, very, very important one. What is the deformity you can see? Let's see the keywords if we can just sketch out something. 7-year-old boy, a child, right? He fell, so we have a case of trauma. A child, trauma with outstretched arm. So outstretched arm is the common mechanism of injury for any bone in the upper limb, right? Clinical findings are presented in the image below. What is the most likely diagnosis? Now, what do you see? What deformity is it? What do you see? What deformity is it? What do you make out? The deformity's name? How will you label this deformity? Come on, deformity. The first word, cubitus, very good. Ujjwal, absolutely right. So cubitus here for elbow, and the part of the limb distal to the joint is going medially, so it is cubitus varus. It is cubitus varus. So cubitus varus, perfect. This is cubitus varus. Not gun shot. It is gun stock, beta. It is not gun shot. It is being called as gun stock deformity. Absolutely right. Okay. So where do we see this? In which condition do we see this? This is linked to what? Is this linked to the trauma itself or the complication of the trauma? When do we see cubitus varus? That's an important question, right? When do we see cubitus varus? Complication. What complication are we talking about? What complication are we talking about? The complication has to be the malunited. It has to be malunited fracture supracondylar humerus. So please remember, these kind of deformities are not a part of every supracondylar. These are a part when the supracondylar has gone into the complication. And what complication are we talking about? The complication we talk about is malunion, right? So undisplaced supracondylar fractures can never have this deformity, right? Malunion, yes, that can have. Proximal humerus fracture, no. Dorsal displacement supracondylar fracture of humerus. Now see, dorsally displaced supracondylar fracture of humerus is also a right answer. It is not wrong, right? Why so? Because we know that what is the most commonest displacement we know? The most commonest displacement once the fracture happens is the extension type injury. It is the extension type injury. And this extension type injury means when the fragment goes behind, just behind the elbow, right? So extension type injury, when it goes into a medial displacement, how do we learn that? Posterior-medial displacement. So only dorsal displacement is not the reason. What is the reason? Is the posteromedial displacement, right? So extension type is the most commonest one. That is why the option C is the best one, not only this. So what is the reason for the deformity, the gun stock we say? It is posteromedial displacement of the fragment, right? It is only extension type is like 98%, 99% time of the trauma. It will be the most commonest type of injury we have, right? But reason for deformity is the posteromedial displacement. So option C suits the best. All right, malunion, very good, absolutely right. Thank you so much, boss. Thank you so much for your kind words. So that is what we are made for. No early morning sessions, late night sessions. अब exam आ रहे हैं बच्चों के, तो we have to be with them, right? I just thought to make them revise, और सुबह सुबह उठने का एक reason भी हो जाता है that they are doing something very productive. So that's the only reason to be like, you know, with the students near to the exams. So a 30-year, next one. Okay, I hope this is fine with everyone. Number 3 is fine with everyone. Number 4, 30-year-old male patient presents to the OPD with a complaint of pain in the left thigh region. All right. So keywords, let's catch the keywords. The adult male, right? Pain, left thigh, right? Coming in OPD, so not an acute trauma. Upon history taking, he complains that the pain is often worse in night. Very, very key word here, very important keyword here. Pain which is more in night. He says he has been taking aspirin to relieve the pain. Can you tell me the answer? Option की जरूरत ही नहीं है यहाँ तो. Pain है more in night and aspirin is relieving it. So what do you say? If aspirin relieves the pain, what do you think it is? If aspirin is relieving the pain, what is the answer? What is the diagnosis? X-ray we'll see later. अब मुझे बताओ aspirin से क्या आना चाहिए दिमाग में? Very good. Absolutely right. It is osteoid osteoma. Very good, beta. First class. Right? So aspirin लेने पे relief, it comes in only one benign lesion, that is your osteoid osteoma. How do we figure out osteoid osteoma? So for tumors, I have given you the keywords. How to approach any case of the bone tumors? 3-step approach. Number 1 is location. Look at that, whether it is epiphyseal, metaphyseal or diaphyseal. Number 1, location. Right? Second is always to look for the nature of the lesion, whether it looks malign or malignant. And then number 3, we see any of the special feature. Right? Now look at this X-ray. The epiphyseal area, metaphyseal area or diaphyseal area. Right? So epiphyseal, metaphyseal, we know diaphyseal area is involved. No periosteal reaction, so it has to be a benign one. And what is the special feature? This all whiteness all around. You can see this all whiteness all around, right? So sclerosis around a lesion is a feature of what? Only one. That is your osteoid osteoma, right? Pain relieved by aspirin. Okay, pain relieved by aspirin. Okay, so it cannot be a tuberculosis. Had it been a tuberculosis, you should have been seeing more other involvement of the bones. We know tuberculosis most often involves vertebra. Eccentric surrounded by sclerosis and diaphysis. Very good, Ramya. Perfect, beta. Absolutely right. Right. So this has to be osteoid osteoma, and these are the 3 steps to approach any bone tumors. Right. Don't miss out the step and don't skip the step. You always have to follow the steps here. Number 1, number 2, number 3. We never change the sequence here. Never change the sequence here. Okay. All right. So we have another question coming up. अभी जो हमने पढ़ा वही आ गया वापस. All of the following are seen in the terrible triad of elbow except. So elbow dislocation. Usually it is a posterior dislocation. Radial head fracture. Olecranon fracture. Is it? No. C कैसे होगा? हाँ, that is right. You are right. Exception उन्होंने पूछा है. And the coronoid process of the ulna. Right. So this is not a part of the terrible triad. Right. अब terrible triad of elbow जब पढ़ रहे हो तो I want you all to recall the terrible triad of knee as well. Right, so always remember the terrible triad of knee as well, which is very very important. Right, terrible triad of knee has been your INS at MCQ, तो ये आपको पता भी होना चाहिए. terrible triad of elbow तो पढ़ लिया. knee में क्या क्या होता है? Can you name the structures? 1 2 3. Right, 1 2 3. terrible triad of knee. What do you say? terrible triad of knee. क्या क्या होना चाहिए? medial menisci, ACL and MCL. Dr. Goals. Okay, very good. So medial collateral ligament, very good. Then we have anterior cruciate ligament, and then we have the medial menisci, right? The medial side under more stress usually ruptures first, right? So this is called the terrible triad of knee. The O'Donnell's terrible triad and the elbow was Hotchkiss terrible triad. So we have 2, O'Donnell's and the Hotchkiss terrible triad, right? So terrible triad of knee, terrible triad of elbow. Nobody should be missing it out. ACL, MCL and medial menisci. Absolutely correct. Utkarsh and everybody. You have answered it very, very accurately, right? So these are some of the questions, 5 questions. Now see, by the means of these 5 questions, we have revised so much, right? We have revised so much. So don't just take a question to solve that particular, point only. Always look at the other options also, right? जब भी अपनी app में भी question solve कर रहे हो तो do the same thing. Every question is not a single question. Every question has actually 4 questions, right? 3 options and the 1 main question. So you should be very, very clear about what you are marking. All right. Okay, so this is your one of the papers we have. Another one, let's solve another one as well today. July 23 paper. Okay, the patient has a painless palpable bony mass near the metaphysis of a long bone. X-ray was done which shows the following finding. What is the answer? ये तो simple है. Everybody can answer ना? Everybody can answer. So it is C. Okay, all right. It is osteochondroma. What kind of osteochondroma? We know 2 kinds of osteochondromas. We know 2 osteochondromas. One is a sessile one, right? One is a sessile one and other one is a pedunculated one. Sessile and pedunculated one, right? Sessile and pedunculated osteochondromas. Okay, so this one is which one? The pedunculated one. And what is so special about these pedunculated ones? What is so special about these pedunculated ones? Special about the pedunculated one, they will always, the peduncle usually always go away from the joint line. It doesn't come towards the joint line or the growth plate, right? They don't damage the joint line or the growth plate, right? So this one will have a cartilage cap, you should know. And this cap, the cartilage cap, usually grows to a few millimeters or less than 2 centimeters. It never goes more than 2 centimeters. If it is going or growing more, we know it is going malignant. right? Now, see, osteochondroma, to theek hai, it is important one, but definitely along with osteochondroma, this is a cartilage lesion. So you should also remember that when you talk about a cartilage lesion, in the cartilage, we have the most commonest location for this chondromas as an chondroma. What is the most commonest location? Which is the most commonest bone involved? What do you say? Which is the most commonest bone involved in an chondroma? These are phalanges of the hands, right? These are phalanges of the hands. All right. So phalanges of the hands are the most commonest one. Perfect. Okay. There are two syndromic associations which I want everyone to remember. Number one is Olliers. Second one is Maffosi. What is the difference in Olliers and Maffosi? What is the difference in Olliers and Maffosi? This Olliers will be whenever somebody has multiple enchondromas, right? Olliers is whenever somebody has multiple enchondromas, right? And whenever somebody has chondroma along with hemangioma, whenever somebody has chondromas along with hemangiomas, right? So what is the challenge with them? Don't forget Olliers and don't forget Maffosi. Olliers is a potential question, theoretical in fact. Maffosi can too be a theoretical question sometime. The relevance here is Olliers have got some 30-35% chance of conversion into malignancy. Maffosi has almost 100% chance of conversion into malignancy. So we should be aware of them, right? So tumor of the cartilage outside the bone is osteochondroma, and tumor of the cartilage, when it is occurring inside the fingers, phalanges, the hands, it is enchondroma, which can come up with Olliers and Maffosi. Don't forget this, right? Don't forget this. These are two important, cartilage. Oh, the favorite one of Ashwini sir and mine too, right? The combined part of both of us. Nerve damage in the following image. It was a simple question asked years back. Don't expect these simple question, right? But still, if they come simple, that's wonderful, nothing like that. But if by chance they're not simple, you should be knowing the clinical aspect of this, right? You should be knowing clinical aspect of this. If the patient is having a wrist falling down, right? It is the radial nerve, okay? So where exactly is the site of radial nerve injury, if you can figure out? Is this in the axilla? Is this in the spiral groove? Is this in the shaft area, right? You can see the elbow attitude here. Elbow is already extended. So elbow extension means that is the injury in axilla, is the injury in the spiral groove, is the injury in the shaft area, where is the injury? So most likely it is a shaft injury, right? It could have been an injury to the spiral groove also, but then again, that will be having a weak extension, not a complete. So we don't know whether it is a weak one or a complete one, but yes, for sure, injury is not in axilla, right? For sure, injury is not in axilla. Yes, most likely it is a shaft injury. Very good. The wrist drop and the fingers are also flexed, right? So most likely it is a shaft injury. Very good. Which splint you are going to use? Which splint you are going to use here? What do you say? Splint, name of the splint? Which one? Cock-up splint. Very good. Now, how many types of splints you know? If it is a cock-up splint, how many types of splints you know? One is a static one. Other one is one is static one, other one is dynamic one, right? So which one do you use post-surgical? Immediate post-op, which one to be used? One is dynamic, one is static. सर्जरी की आपने, सर्जरी करते कौन सा यूज करेंगे? डायनामिक, स्टैटिक। सर्जरी करते ही तो आपको उसको रेस्टिंग स्टेज में रखना है, राइट? तो इट इज इसीलिए क्या यूज करेंगे? स्टैटिक वन। एंड व्हेन यू वांट टू गो फॉर फिजियोथेरेपी, तब क्या यूज करोगे? डायनामिक, राइट? सो यही तो मतलब है। डायनामिक पहचानोगे कैसे आप एग्जाम में? स्प्रिंग्स। एनीथिंग विच अलाउज यू द मोबिलिटी इज अ डायनामिक वन, राइट? एनीथिंग विच अलाउज यू मोबिलिटी इज अ डायनामिक वन. Anything which is keeping the limb in a static fixed position is a static one, right? तो सर्जरी करते ही तो हमें रेस्ट देना है for the healing part, so we use static, and for physiotherapy purpose mobility we have to use dynamic one, right? This is perfect. Okay, perfect. All right, so now third one. ये बताओ, if you can, cartoon जिसने देखा है they can answer this question. What is happening here? Popeye. Very good. Popeye cartoon याद है सबको? So this is the rupture of which tendon? A. Which part of biceps? Usually which part of biceps gets injured? Long head, short head? It is usually the long head of biceps, right? So this is Popeye sign, the rupture of the biceps. ओके बहुत सारे वीडियोस देखते होगे इंस्टा पे, पीपल हु आर डूइंग जिम लिफ्टिंग लॉट ऑफ वेट दे गेट द रप्चर ऑफ बाइसेप्स. So it is usually the long head of biceps which gets a rupture. So image based question. All right, another interesting one. 11-year-old, देखो, skeletally immature patient, 11-year-old, presented with the outward angulation of the forearm in relation to the upper arm. So we can see that the arm angle and the forearm angle. We can see that as compared to the arm, the forearm is out. What deformity is it? First word, cubitus. Yeah. Second one, cubitus. Verum. क्या कर रहा है परमार?
Valgus.
Why valgus?
Because it's going laterally.
Very good. What is going laterally, the arm or the forearm?
Forearm.
Very good. So it is cubitus valgus. Very good. Where do we see cubitus valgus? In which condition?
Tardy.
No. Don't mix up. Supracondylar. Oh, come on, Ujjwal. अगर supracondylar में what is the commonest complication you have? Is it malunion or non-union? Supracondylar में what part of the bone is getting involved? No. In supracondylar first, which part of the bone is getting involved? Is it epiphyseal, metaphyseal, or diphyseal?
Epiphyseal.
Oh, come on. Epiphysis is end of the bone. Metaphysis. And what do we know about metaphysis? Is it what kind of bone it is? Metaphysis. Is it cortical bone or cancellous bone?
Cancellous bone.
Cancellous bone. Does it have more vascularity or less vascularity?
More vascularity.
More vascularity means a good union or bad union?
It's a bad. Good union. Good union.
Good vascularity means, more vascularity means a good union or bad union?
Good union.
Good union. So good union means linked to what? Non-union or malunion?
Malunion.
Malunion. And how does the fragment goes in supracondylus? Where does the fragment goes in supracondylus?
Posterior.
Posterior. And then medial side or lateral side?
Medial.
Medial. So what deformity you get in supracondylus then?
Cubitus valgus.
If it is going medial, how can it be valgus? If it goes median, it has to be what? Varus or valgus? Varus. That is why in supracondylus, what do we get? Varus. And in lateral condyle, now what is the trouble? What do we get? Diagnosis. In lateral condyle fractures, what happens? What is the muscle attached to the lateral condyle of the humerus? What is the muscle group taking origin?
Extensors.
Common extensors. So if extensors keeps on pulling the bone, will the bone will be able to unite?
No.
So what is the complication?
Non-union.
Non-union. And if there is non-union of the lateral side, if there is a non-union on this side, this medial side is intact. This will keep on growing normally. And there is going to be a step over here. So how will the elbow, how will the forearm go now?
Cubitus valgus.
Exactly. So where do we see cubitus valgus? We see cubitus valgus in non-union of the lateral condyle of humerus. Right? And now, if this valgus keeps on increasing and increasing and increasing, now there's going to be a stretch on this side, medial side. And what is the structure under this medial side of the elbow? Ulnar nerve. And that is what you just mentioned as what? Tardy ulnar nerve. Why tardy now? Why not immediate? Why it is a tardy ulnar nerve, Pelsi? It's a slow involvement. Why? Because this cubitus valgus development is a progressive deformity because of non-union. Now is it clear? Ujjwal and Parmar.
Yes, sir.
ठीक है, गड़बड़ नहीं होगा एग्जाम में?
No, sir.
No, supracondylus is metaphyseal, so it has to unite. So it will go into malunion. Lateral condyle, because of the pull of the extensors, it goes into non-union. And that is why it causes progressive cubitus valgus and there will be tardy ulnar nerve palsy. Right? So don't forget, these are two very, very important questions for your exam. Don't miss out them. Right? This is going to be very, very important. Okay? गड़बड़ नहीं होना चाहिए इसमें. So this one, the answer is cubitus valgus. So it ideally should be written as progressive valgus, but anyhow. All right. ये वाला question I don't know when it was asked. It was not asked. So it is an old question which we keep on seeing in all the recalls. 14-year-old child, OPD with noticeable deformity of the neck and the upper back. On physical examination, the scapula is observed to be elevated, right, and medially rotated, giving the appearance of an equilateral triangle. See, when you see the scapula which has failed to descend down, the right side it is down, left it is not down. So what is the deformity? What is this abnormality? What do we call this? Failure of descent of scapula. Failure of descent of scapula, it is called as Springles. Yes, it is called as the Sprengel's deformity. Okay, but don't get into this trap here. See, when they are mentioning only scapula, it has to be Sprengel. But along with the Sprengels, there will be scoliotic curve, which you can see in the X-ray. There will be no neck or the short neck like this. So scoliotic curve, short neck, failure of descent of scapula, they all, when they combine with multiple other anatomical abnormalities in the child, then we call it a Klippel-Feil syndrome or the Klippel-Feil deformity. So it is called Klippel-Feil syndrome. Basically, syndrome, it usually means multiple, compilation of multiple abnormalities. So Sprengel is only the failure of descent of scapula. And along with Sprengel, if they mention, by chance, if this question comes again, and they ask you that there is a deformity, scoliotic curve, short neck, fused vertebra, then we call it basically as the Klippel-Feil deformity or the syndrome. Okay, so Sprengels can be a part of Klippel-Feil also. As it is a syndrome, so it can be a part of Klippel-Feil also. Right, so this was asked once sometime. It is not a big deal where you are going to miss it. Okay, so this was an image based. Okay, right, another very important one. Another very important one we have. 30-year-old patient has limited hip movement and complains of pain and discomfort in the hip region. Which of the following tests you will do to identify fixed flexion deformity? अब ये बताओ, first of all, the fixed flexion deformity of the hip, it is seen in which condition? Which pathology can do that? Fixed flexion deformity of the hip?
TB of the hip.
Very good. So it has to be the tuberculosis of the hip. Perfect. Which test is to be done?
Thomas test.
Not to be missed. It's very important. High possibility of being asked in your exam. See, TB hip to pura topic important and no one should miss it. Right? TB hip is definitely one of the most important patients you have. Right? So that is Thomas test. Then we have this one. थोड़ा ट्रिकी है, थोड़ा ट्रिक बना दिया गया है, but if you can see, a 27-year-old male was climbing the stairs. Suddenly he fell and an iron nail hit on his neck. After the injury, the patient is having a hard time shrugging his shoulders and is having a difficulty in turning his head. This might be due to injury to spinal accessory. Very good. Chalo, you have caught it well. This is spinal accessory. Very nice. This is, see, बहुत सारे क्वेश्चंस ऐसे होंगे जो एनाटमी और ऑर्थोपेडिक्स में ओवरलैप होंगे. So definitely हमारा base is always going to be anatomy. Don't forget anatomy, but learn to present that anatomy in a clinical way, right? So बहुत सारे आएंगे ऐसे questions. Housemaid knee किसको कहते हैं? Housemaid knee. Which patella? Pre-patellar, supra-patellar, infra-patellar, सारे patellar है. Pre-patellar bursitis. What is that infra-patellar bursa?
Clergyman's.
Very nice. So this is clergyman's. This is clergyman's. This one is housemaid. Okay, very good. All right. Again from anatomy. Which is the bone most likely to be fractured in an injury to the anatomical snub box?
Scaphoid.
अच्छा चलो ये बताओ. If in scaphoid, if by chance a patient comes to you with the tenderness in the anatomical snub box and you get an X-ray done, right? आपने X-ray करवा लिया and post X-ray you are not able to see any fracture. What to do? Immobilization. So if on X-ray there is no fracture visible, the next step has to be immobilization. कौन सा plaster देंगे आप? What kind of plaster is to be given? Immobilization में what kind of plaster is to be given?
Glass holding.
What is the meaning of the glass holding? Simple question. Thumb blocked or thumb spica? Very good. It is called thumb spica. Glass holding is just a position. That plaster has to be a thumb spica. Basic principle हमने पढ़ा था ना, thumb spica. Thumb to be blocked or no in the scaphoid injuries. Glass holding तो position है. Thumb spica. Thumb is to be blocked or no? What do you say? Yes. So thumb has to be blocked in scaphoid. Same principle. Blocking a joint above and blocking the joint below. So Colles का plaster कैसे देते हैं? What is the difference with Colles plaster?
Handshake position.
What is that handshake position? Handshake position क्या है? Palmar flexion and ulnar deviation. That is very good. And that is what you are calling as the handshake or the shake hand position. Very good. Right? So thumb spica in the scaphoid and Colles में handshake position. That is to be given. So thumb is to be immobilized only in scaphoid. Right? Thumb is to be immobilized only in scaphoid. All right. So 2 papers I think worth discussing.
Yes, sir.
ठीक है. So अभी आज के लिए I have taken almost like an hour. So 2 साल के papers we have done. We'll be doing some more as well. Okay. So let's keep on revising. And for everyone out here, we are, yeah. So for everyone out here now, we have started with these 5M sessions. Okay. So now every day you are going to have these 5M sessions, and OBGY, orthopedics, part of anatomy, my part of surgery, I'm going to take that as well. Right. So let's stay connected. These will be taken up early in the morning so that you all get up and you all get used to, getting up in the morning, and day has to be the fruitful one. Right. So today we have started a month broadly from now for 17th of January. अच्छे से पढ़ाई करो. Stay on track and don't miss out any important thing. Right. लेकिन इसका ये मतलब नहीं है कि you stay on Instagram, Telegram or on YouTube or somewhere. Utilize time very, in a fruitful manner. हर दिन important है अब, and हर minute important है, and it has to be utilized in a very proper way. All right. So it's been an hour, and I hope everybody is now widely awake. अपना दिन अच्छे से spend करो. Plan your day in a proper manner. And at center you have today the pharma revision coming up. अच्छे से revise करो. And कल you will have ophthalmology revision. उसको अच्छे से करो. And from day after tomorrow you are going to have your complete schedule. Day wise, hour wise, what you're supposed to do, we are going to do that. Right? ठीक है जी? Everyone?
Yes, sir. Yes, sir.
All right.
Yes, sir.
चलो, thank you so much for joining in, and let's stay connected. और अब सब सारा focus सिर्फ पढ़ाई पे. चलो, have a wonderful day. Thank you so much everyone.
Thank you, sir.
चलो बच्चों, on Insta as well. पढ़ाई करो. इंस्टा स्क्रॉल मत करते जाना. नाउ स्विच ऑफ योर इंस्टा, एंड टुमारो मॉर्निंग अगेन वी आर गोइंग टू मीट विद सम अदर सेशन. ओके. सो कल मोस्ट लाइकली मैम इज गोइंग टू टेक द सेशन. ओके. एंड फॉर टुडे इट वाज ऑर्थोपेडिक्स वी बिगिन, एंड वी आर गोइंग टू कंटिन्यू लाइक एवरी सेशन. वी आर गोइंग टू कंटिन्यू टिल योर एग्जाम्स. सो stay hopeful, stay positive, stay happy, and keep studying. Right. Thank you so much everyone.